my name is Mick Cooper. I'm a professor of counselling psychology at the University of Roehampton. And I just wanted to do a little talk about integration in psychotherapy, because I guess, a lot of the time in counselling and psychotherapy, we talk about integration and integrative approaches or practicing integratively. But what does it actually mean? What is integration? And how do we do it? How do we think about it? And there's been some useful work that I think often people in the therapy field aren't that familiar with. So I wanted to talk a little bit about that. When we think about integration, we can think about it as the putting together of different theories and practices. It's combining two or more approaches, and I guess we can talk about combining two or more what we might call pure form therapies or kind of classical therapies or single modality therapies, we might refer to. So we're talking there about person-centered, psychodynamic, CBT, Gestalt. But of course, what's a kind of an integrative therapy and what's a pure form therapy changes over time. For instance, CBT in many ways is an integration of cognitive and behavioural approaches. But these days we tend to think about it as a pure form therapy. Something like EMDR, you might say, is integrative, but now we think about that as a pure form therapy. So there's no clear distinction, but pure form therapies tend to be the more established ones, and integrative therapies are when we bring those established ones together into a different combination. But there's lots of different questions here, and again, I hear often students on integrative courses talking about the way that these issues aren't really kind of unpacked. Sometimes you're given one approach and then another approach, and then you learn a bit of CBT, you learn a bit of psychodynamic, learn a bit of person-centered, but then how do they actually come together? What do we do? One of the questions, for instance, is when we think about integration, like what level of integration are we thinking about? Are we talking about, say, if you've got different placements, like you do psychodynamic at one, CBT at the other, is that integration? Probably not, isn't it? It doesn't quite feel like integration. What about between different clients? So with one client, if assuming you have the skills and the training, you do CBT. Another client, you do psychodynamic. Another one, you do back to CBT again. Is that integration? Probably not quite. I mean, if you were working like using different approaches in different sessions, that feels probably more like integration and being an integrative practitioner. And certainly if within the session you were moving between person-centered, maybe psychodynamic, then that might be what we think about as more kind of an integrative approach. But it also raises the question, about how do we decide which theories or practice to use? Like, how do we choose our integrative model? When, for instance, might we switch from person-centered to a psychodynamic way of working, or when would we, with a particular client, for instance, start using dialectical behaviour therapy if that's our training? So again, there's some quite challenging questions really around integration that kind of need working out, and it partly depends on which particular model of integration that we're talking about, because integration means quite specific things, and that's mainly what I wanted to look at in this talk, is about these different models of integration. There's a fantastic book, it's bloody expensive unfortunately, but it is a fantastic book called The Handbook of Psychotherapy Integration, and that has a lot of chapters about different models of psychotherapy integration. There's a brilliant introduction there from a colleague of mine, John Norcross, which is a primer on psychotherapy integration. And if you can get hold of that, you might need to do it through a library. That gives you such a really solid introduction to the different models of integration that are out there, and that I'm going to talk through and add a little bit to. So do try, and if you've got library access, do try and get hold of that handbook to find out more about these different models. So in that chapter, and more generally, people tend to talk about four main models of psychotherapy or counselling integration. Now, the first one is what's called theoretical integration. And theoretical integration is where people bring together two or more approaches, pure form approaches, to create a new kind of therapy, a new model, a new form of therapeutic practice. So you might think, for instance, of can you think of what would be a form of theoretical integration? Classic one is cognitive analytic therapy. So that's where Tony Ryle brought together ideas from cognitive therapy, ideas from psychodynamic therapy, but also created his own kind of brand new approach, fantastic approach if you get a chance to read about it, which uses some cognitive ideas, some psychodynamic ideas, kind of mixed together into a new combination that integrates them. And what you see in cognitive analytic therapy is that there's a really deep, rich integration. It's not just a question of kind of slapping these two things together. Let's do a bit of CBT here, let's do a bit of psychodynamic there. There's a whole new way of thinking about the person that draws on these ideas, and particularly when we're talking about integration. And if you're writing about integration, for instance, an essay, or applying as an integrative practitioner for an accreditation, then it's really important to be able to show how these different approaches come together. So you're not just saying, well, I do a bit of attachment theory, but then I also like person-centered approach and a bit of CBT here. Like if you're holding an attachment theory perspective, then how do person-centered ideas of unconditional positive regard or empathy come into that? How does it all fit together? You need to show that there's something coherent there joining them together, and you've really thought through these issues so that you're not just doing one thing and then another with a client as you feel like it, which for some clients certainly can be very has a potential to be kind of confusing, like why are they doing this, why are they doing that. So there needs to be a coherent integration. So theoretical integration are these models of therapy that have been developed. Other ones might be emotion focused therapy, which brings together person-centered therapy and Gestalt therapy, or there's millions. Mindfulness-based cognitive therapy, mindfulness-based existential therapy. You can think there's so many different combinations that you can have, but they're kind of particular models in themselves that form these theoretical integrations. What you have then is and each of these different approaches to integration are different kinds of integration, if you like. They're not mutually exclusive in any way. You can combine them in lots of different ways. Although, as a practitioner, you might kind of identify more with one than the other. Assimilative integration is more of an individual level integration. It's not a particular model. It's more where you start with a particular form of practice, say person-centered or psychodynamic. And this would be true for a lot of us as therapists who identify as integrative, that we start with one of these models and then we bring into it theories and practices from other models. So we might start, for instance, with CBT or person-centered therapy, and that we do a training in that for a couple of years, and then after a while we start bringing maybe a bit of Gestalt therapy and some of the ideas from Gestalt therapy, or some of the methods, or maybe some creative techniques, so that we develop a kind of unique individual style, our own particular approach. And there's people who have written about and developed what they would call as a kind of personal approach to integration, which is kind of rooted around the individual and the individual person, the person as the practitioner. But assimilative integration means that there is that kind of drawing together, and again, like theoretical integration, it's a coherent integration. It's not just putting things together. There's a coherence to how we draw these things together, and why and why and when we apply one and perhaps not the other. But the difference is this is an individual model, whereas theoretical integration is more a particular form of practice that is out there that some people might take. And of course, we might assimilate into our integrative position particular forms of theoretical integration. I might integrate some ideas from CAT, cognitive analytic therapy, for instance. So, as I say, these approaches aren't mutually exclusive. What we come on to then is a third form, which is what's called the common factors approach, which again is a different slant on on integration. And what happens with common factors is that people have written about this, and this particularly comes from a kind of research base. Often the people who developed it have got more of a research perspective, is that it's trying to get away perhaps from particular schools, particular approaches, pure form, or even kind of integrative theoretical integrations, and more thinking about what are the underlying factors across lots of different approaches that are the kind of driving factors of change. So this is, you can see here, for instance, an example from Mike Lambert, one of the world's leading psychotherapy researchers, and he wrote a number of years ago now about this idea that if you look at change, it's around 40%, around half of what drives change is the client factors like involvement and engagement and motivation. Then you've got the relationship, and nearly all the common factor models put the relationship really central. Then you've got hope, the kind of placebo effect of clients just believing change is going to happen. And then Mike talks about some of the variants being about the specific model that's taken, and for instance where there's maybe phobias, then an exposure approach might be more helpful for more clients at different particular points in time. So the common factors approach isn't talking about a particular combination, it's more going into therapy maybe less orientation specific, more holding that a particular relational stance. Patricia Clarkson, for instance, her relational model looks at different kinds of relationships across different therapies. The work of people like Scott Miller, Barry Duncan, their common factors model is based around the idea particularly of using feedback. I mean, they would suggest it doesn't matter too much where you start, you can have any particular starting point. What's important is you listen to the feedback, check how the work is going with the client in terms of outcomes, in terms of are they valuing the work or not, and then if they are, great, keep on doing it. If they're not, then maybe you need to do something different. So it's kind of integrative thinking maybe, and an integrative practice around these common factors that again could be, your starting point could be cognitive analytic therapy, but you're kind of assuming that these cognitive factors of change rather than maybe a more schoolist pure form perspective that would see the change as being down to the particular model that's being used. Now, the fourth approach that is classically talked about is eclecticism, and this kind of got a bit of a bad press. And I guess the reason for that is that in eclecticism, the different practices are kind of more spread out, as the diagram kind of suggests, that rather than having this kind of tight, coherent, underlying rationale theory, if you like, that you'd have in theoretical integration or assimilative integration. With eclecticism, it's more the kind of toolbox image, trying one thing with one client, another approach with another client, without necessarily bringing them together. The attachment theory, we're going to work with this one from an attachment theory perspective, but this client, we're going to work with a more CBT perspective, for instance. And having said that, probably the best known form of eclectic practice was Arnold Lazarus's technical eclecticism, and his approach was called multimodal therapy. Brilliant, if you get a chance to read about it, multimodal therapy. It's a fascinating approach which was based around a kind of, what he did is to have this coherent assessment called the basic ID that looks at these kind of bit biological and affective different components, and then you use that as a way of working out what method that you might use. And the techniques might be it might be chair work, it might be psychoeducation, it might involve listening. You can basically use anything. Obviously you have to be a very experienced practitioner to be able to use such a wide berth of different techniques, but it was a very coherent approach, but it just didn't worry too much about the theoretical integration. And I guess the challenge there is that you have to be careful if you're doing an assignment or going for accreditation about describing yourself as eclectic, because it doesn't have to be, but it can be that not having a theoretical integration is kind of an excuse for not having to think about some of these complex issues, like how does person-centered and psychodynamic sit together, which is why assessors, accreditors tend to be a bit wary about it, because it can be a kind of stand-in for not thinking through things, or what's called syncretism. Syncretism is a word that means just kind of mishmash of stuff just chucked together, and you want to avoid that. You want to avoid that because for clients that can feel quite chaotic. But eclecticism absolutely doesn't need to be like that, and actually I think that these eclectic approaches often do have very coherent rationales behind them. Now, I just wanted to talk about two more, and this relates to the work that I've done with John McLeod and Wendy Dryden and many other colleagues on pluralism that you can find out more at pluralisticpractice.com. And these are there's two ways that we've thought about pluralism. It doesn't help stuff really, it makes it more complicated. But they do link into how we think about integration. And we've talked about the difference between pluralism as a philosophy and pluralism as a particular practice. Pluralism as a philosophy, and one of the things about pluralism is that it comes out really from a person-centered, humanistic, existential worldview, one which is particularly about kind of valuing different. If you think about person-centered values, about unconditional positive regard, it's about really valuing different ways of doing things, and also about valuing differences across people, recognising that people are different and people have different ways of doing things. So pluralism as a philosophy is a kind of a meta stance on therapies as a whole. We're not talking about a particular practice here, and in that sense it's different from these other forms of integration that are specifically about practice. And again, it's not mutually exclusive. You can have a pluralistic philosophy within which an integrative practice, and I'll talk about that in a sec. But pluralism as a philosophy is holding that valuing of the different approaches and recognising that there isn't one best therapy. Pluralism as a philosophy really was a kind of response or reaction to schoolism and the dogmatism of this is the right approach or that's the right approach, and trying to say, well, actually lots of different therapies can be helpful. Certainly the evidence would suggest that lots of different therapies tend to work, and that different clients need different approaches at different points in time. Now, that is not to say that we can do all 450 different kinds of therapy. We can only be trained in certain approaches and develop, and we want to develop skills in specific things. It might be a preference, it might just be a limitation of our training. Nobody can develop skills and everything. So it's not saying we can do everything, but a pluralistic philosophy is about valuing and holding that value for therapy A and therapy B, for different models of theoretical integration, for these different common factors, and recognising that they all have the potential to have a place, rather than getting into my therapy is better than your therapy. And that different clients can benefit from different things at different points in time. So that's pluralism as a philosophy, and that of course can include, as we can see here, an appreciation of common factors, appreciation of different forms of theoretical integration, and an appreciation of different assimilative integrative models. And then we have pluralism as a practice, which is kind of applying that same pluralistic thinking. Pluralism doesn't start with psychotherapy. Pluralism is a philosophy that goes back to questions of ontology, what exists, epistemology, how do we know things are there. Pluralism is there in religion, pluralistic attitudes to religion. But it's always about valuing difference and diversity. So pluralism as a philosophy of therapy is about valuing the therapy field as a whole. Pluralism as a practice, and if you hold a pluralistic philosophy, if you practice in a pluralistic way, you need to hold a pluralistic philosophy. But if you hold a pluralistic philosophy, it doesn't necessarily mean you will then practice in a pluralistic way. You might be a person-centered practitioner and just hold that valuing of lots of different approaches, and recognise that some clients need person-centered therapy and want it and value it. Some clients other times don't, and you might refer on. But there is also a pluralism of practice, which is valuing there's different approaches, although of course we can only be trained in a certain number. So it might be using approach A and approach B. But at the heart of pluralism as a practice is shared decision making with clients. What that means is that it's about valuing the different perspectives on therapy, not just assuming that our perspective as the therapist is the right one, that we should dialogue and collaborate and work with clients to work out what's best for them. That's not about just saying to clients, look, you decide. It's really about the dialogue. It's about finding that meeting place between a paternalistic therapist-led approach and a more kind of hands-off client-directed approach, where we just give the power to the client. It's about using our understanding, our knowledge, our skills, but also how much clients want to contribute, and that can really vary. Some clients really want to be involved in shared decision making, some clients not so much, and of course being pluralistic means being responsive to that and recognising that different clients just as they want and can value different approaches at different times, so that they can want and value different levels of shared decision making at different points in time. And but that shared decision making, or that attempt to share decisions, is what makes pluralism as a practice unique and somewhat different from other forms of integration, particularly assimilative integration. Now, some people would say, I mean, a colleague of mine, John Norcross, would say that when we talk about integration as a practice, we're talking about personalisation, we're talking about shared decision making. We don't need another term for it. It doesn't matter so much what we call it in a sense. What's important is what we do. From a pluralistic standpoint, we wanted to kind of really emphasise that collaborative element, and we think that's a useful term. If it's not useful, then the important bit is how we work with clients. So I hope that's given you some idea of how people think about these different forms of integration. You might want to think for yourself about, if you identify as an integrative practitioner, well, what kind of integrative practitioner are you? Are you assimilative integrative? Probably you are in some format, but how much does pluralism as a philosophy lie behind that? How much is your work around shared decision making? Would you see yourself as a pluralistic in practice? And then how much do you believe in common factors? How much do you have a kind of model specific approach, or how much do you believe that common factors like the relationship, like empathy, are the driving factors of change? And how coherent is it? How much do you think it's important to have a coherent theory underlying it, or how eclectic are you? And there's no right answer here. There's no right or wrong, but I hope this talk has helped you think about some of these questions and reflect on some of the issues there. So thanks for listening.